Here we go. Hi everyone. So it's Jane Muir here, calling in, and I'm actually in Melbourne, Australia, and in lockdown like you guys. And I'd like to start by saying that we're all thinking of you over there in these difficult and interesting times. So hang in there, and hopefully we'll all get through this together. So today I'm going to talk about fibre and gut health with Kate, and I'm actually going to just focus, my part of the talk is really just focusing on fibre in general and gut health in general, because fibre is such a complicated area, and it's important to understand, I guess, the complexity of fibre and its role in gut health. And then we'll talk with Kate a bit more about the implications for people who've got IBS. So let's get going. So we're all interested in eating our way to good health and gut health in particular, but there are so many different types of fibres and or indigestible carbohydrates, and it's difficult to know which types and how much we should be eating of these. So what is a healthy gut? So optimal health for humans is very simply just adequate absorption of nutrition. So anything that we eat, we need to be able to absorb and to fuel our bodies and make sure we stay healthy and strong. We want the absence of infection and inflammation and disease, of course. And very simply, we also want good laxation and prevention of constipation. Good this is one of the most commonly presented problems that we have as dietitians and health professionals, is just good bowel habit, if you like, and good bowel function. Constipation affects a very large percentage of the population. It can be a particular problem, of course, for our patients with IBS. So that's just very simply, what good gut health would mean. There's also, of course, the microorganisms that live in our gut now. So let's talk about colonic contents and what actually reaches the colon. And there's one of the two major dietary components that can arrive in the colon are the carbohydrates and protein. Now, the protein can come from dietary sources. It also can come from endogenous sources, which is just the cells that line the gut. Carbohydrate will come from, of course, dietary sources. There's a wide range of carbohydrate classes that can actually find their way into the colon. Carbohydrate is, really particularly important in relation to bowel health, because this is the one that we can control and manipulate the most. The amount of protein that reaches the colon is fairly fixed. It's the amount of carbohydrate that can be present with it that we can vary mostly through dietary manipulation. And carbohydrates in the colon have a whole range of effects. They can be involved with just the movement of water into the colon and absorption. Obviously production of gases, a range of gases. And we're particularly interested in the hydrogen sulfide as well these days, but of course a range of gases are produced from the fermentation of carbohydrate. There's also short-chain fatty acids, or commonly called postbiotics, which people are becoming very interested in these days. These are produced as a result of fermentation of carbohydrate in the colon. There is selective growth of certain bacteria, of course, which happens in the colon. There's also toxic byproducts of protein metabolism. This includes ammonia phenols and hydrogen sulfide, which are very important in relation to a number of diseases. And these actually can be lowered in the presence of a lot of fermentable carbohydrates. So again, another reason why we should be focusing on how much carbohydrate reaches our colon. And of course, carbohydrates important in bulking and laxation. In fact, 75% excuse me, of fecal matter is made up of bacteria. So it's a very, the bacteria and the action in the colon is very important for bulking. So key activities of indigestible carbohydrate, there's water delivery, which is important actually in laxation as well. There's bacterial fermentation, short chain fatty acids that are produced, and also the gases. Even the gases can help propel along the gut, sort of help with motility. And of course, there's the bulking and water holding capacity of fibers and bacteria. All of this is important in the proper functioning of the bowel. So which are the major classes of indigestible carbohydrates or fibers, which we are particularly interested in relation to gut health? Well, there's dietary fibers, which is a very broad sort of category of roughage, if you like. And again, it itself is a very complex, covers a vast range of fibers. There's resistant starch, which is another form of indigestible carbohydrate. And of course, there's the prebiotic fibers, fructans, GOS, which are particularly good at stimulating the growth of certain bacteria. So dietary fiber is important in laxation, bulking, hastening transit time, and also produces short-chain fatty acids. The resistant starches are very good at producing short-chain fatty acids, particularly butyrate. Some types of resistant starch encourages the growth of the butyrate producing bacteria, which we know now is important for basically for the fuel that's for colonic cells, has anti-inflammatory effects. It may also protect against cancer. So it's an important short-chain fatty acid that is produced by some resistant starches. But resistant starch is not a great bulking agent. And then we have prebiotic fibers of fructans, GOS, inulin, and these fibers are particularly good at selectively stimulating the growth of the so-called beneficial bacteria, which of course include things like bifidobacteria, also producing short-chain fatty acids. Some of them also are very good at producing butyrate, but they're not particularly good at bulking as well. So you can see here these different types of indigestible carbohydrates are good at doing different things. So they specialize in different types of things, if you like, different types of activities. There's no one type that will do absolutely everything. So here, what about the healthy gut microbiota? We'll be hearing a lot about this becoming very, very popular over the last few years. And it is so complicated and so complex. And as illustrated by this diagram here, it's a whole universe going on inside our gut, a huge ecosystem, complex ecosystem with many organisms. And we're just beginning to understand really what this all means. And we're still really in our very early stages of understanding our community that lives, or this universe that lives within us and on us. But it's no doubt it will have huge implications for health of our gut and prevention of many diseases. But there are certain things we can say in general about a healthy gut microbiota. And it was all about a bit of a balancing act. There's a balance in composition. As we know, this can vary greatly between, the composition will vary greatly between individuals. And there seems to be certain beneficial bacteria and there's pathogenic bacteria, we know that. And basically the way we're looking at it, at the moment, we sort of know more about, we can identify a sort of a healthy profile of bacteria from healthy organisms. But we're still learning really what healthy is. The function can vary. Then certainly the postbiotics of fermentation, not just the substrates, but things that are produced from fermentation from these organisms can vary. And the resilience is another important aspect of balance, is that that community of microbiota must be resistant to disturbance. And so a healthy gut microbiota will resist and stay stable, even though you can have a period of illness, or even following a period of antibiotic use, it will go back to where it was. And this resilience is a marker of a healthy gut microbiota. So there's certain micro or certain bugs we like to encourage. We hear a lot about lactobacillus and bifido. There's a butyrate producing bacteria. There's certain mucus degrading bacteria. We hear a lot about immunosyphilia, which is probably important for a range of anti-inflammatory effects. So we are starting to learn more and more about certain bugs that we might want to encourage in our gut. So I just want to talk about now a more practical guide, really to checking, I guess, if you're getting enough fibre, sort of how we can check our own bowel habit. So let's talk about laxation, and I like to use this sort of analogy of rivers. And here's a nice river, good flowing, nice sort of environment, a very nice habitat to live in if you're an organism. We've got a very constipated river. It's too slow, too dry, too concentrated, that you certainly want to avoid that. Poor habitat to live in. And then you have a raging diarrhea river where things are going too fast and it's too wet. Again, a very poor habitat for our community to live in. So we're really after the good flow, a nice healthy flow, a nice environment for our bowel. And one way we can sort of check this is actually to look at our stool in the toilet, and really use the Bristol stool chart, which has been around for a while, and that really is a marker of your colonic transit time. And we should really be around a rating of 3 to 4. But if you at 1 and you've got these little hard lumps, nuts, it's just too dry, your transit time is too long. You don't want to be there, and certainly you don't want to be at 7 where you have very watery, frequent stools, which is diarrhea. So you need to be around the 3 to 4 level. So you can check that out in your own time. You check that out next time you use the toilet. So what about fibres and fecal bulking? And this is one of my favourite slides because it illustrates very nicely that all fibres are not the same. And basically, these are different types of fibres, and they're looking here at the bulking effects. This is the amount of feces produced per gram of fibre consumed. And you can see here that wheat bran is really one of the greatest bulking fibres that we have. And that is around about 5 or 6 grams, it's about 7 grams of feces produced per gram of wheat bran. So it produces a lot of fecal output compared to something like pectin, which is much lower. And you see a range here. It's very interesting to see that there's certain fruit and vegetables are a great bulking source of fibres. Pectin is not so good. Resistant starch, as I said, it's not a great bulking agent. So it's interesting to keep this in mind, that all fibres are different. Some fibres are particularly good at bulking, and some fibres are less so. So I think, not to forget, I think fruit and vegetables are wonderful sources of bulking fibres. But we really in our diet need to combine a range of fibres to get the best effects. So dietary sources of these types of fibres, and this just illustrates that the range of different fibres that can be found in some foods, but obviously there are some food sources that have got particularly high fibre levels, and you see here the legumes obviously very high. You've got cereals here, you've got some breads. So many foods naturally contain a range of these different fibres, and we need to eat broadly from this range of group to get enough fibre and different types of fibre in our diet. So our diet really does contain this, or naturally contains this complex mixture of these different types of fibres. So how to increase your fibre intake? Well, it's simply a matter of swapping and choosing slightly higher. So here's fibre sources, if you like. And it's an easy sort of just swapping out and exchanging slightly higher fibres sources for others. And this is just an example here of 2 diets. They both look pretty healthy, but one is, diet 2 is much higher in fibre and the prebiotic oligosaccharides, for example, and that's just choosing one food over another, just selecting foods that are particularly rich in prebiotic carbohydrates and also just total fibre. So you can really make quite a difference in your fibre intake. So understanding fibre for gut health. So in summary, it's important to understand the different components of our diet, and that there are these different types or families of indigestible carbohydrates, there's different specialists of indigestible carbohydrates, and we really need to combine all of these fibre types in our diet. There's no single fibre type that's going to do everything for you, so that's a very important point I want to make clear from this talk today. But gut health will mean different things to different people. So it really does depend who you are. If you're someone who has no gut disorders and you can eat widely, you don't have any restrictions on what you're eating, you can tolerate all foods, it's very different to an individual who's trying to manage a gut disorder such as IBS. So a healthy person who has no GI disorders, they're looking for fibre for relaxation and to relieve constipation. They want to feed their hungry gut microbiota. They're interested in the short-chain fatty acids. They want to increase prebiotics such as FOS, GOS, and inulin. They can tolerate these as long as they're not having excessively high amounts and they're slowly introduced. However, a person with GI disorders such as IBS has a very different challenge, because they also want gut health, but it means that they need to look for foods that won't also trigger their GI symptoms, which means it needs to be low FODMAP. They're also, of course, very interested in good laxation, but these fibres they need to be able to tolerate, and this can be very hard for them to find. So really the challenge is to find foods that are high in fibres but low in FODMAPs that they can tolerate. And of course they're interested also in feeding their hungry gut microbiota, but many of the prebiotics they may not tolerate as well, which is the FOS and GOS. So again, a challenge is there for them to find prebiotics that they can tolerate. And I think that is my last slide. And now I'm going to introduce Kate. So Kate's going to continue understanding fibre, in particularly IBS, and the practical guide. Thanks, Kate.
Thank you, Jane. That was fabulous. Okay, guys. So I'm going to be talking more about the practical application of increasing fiber, specifically for individuals with irritable bowel syndrome. So as you know, IBS is a common disorder impacting up to 15% of people, 11% globally, 15% of Americans. These were the objectives for today, which I will just buzz right through. And just wanted to talk a little bit about food and IBS symptoms. And this is was a study done by a researcher looking at about 200 IBS patients and assessing if food was triggering their symptoms. And in this cohort of 200 people, about 84% of individuals with IBS felt like any food they consumed triggered symptoms. The next particular food group that was identified was carbohydrates. And so for today's talk, this is the area that we're talking about. So 70% of this cohort of 200 IBS patients found that carbohydrates were triggering. So this is absolutely an area where we would be thinking about FODMAPs and particularly various fibers that may be triggering their symptoms, FODMAP fibers and otherwise. So we'll talk a little bit more about that. But let's just back up a little bit. I think most of you listening are clinicians and are very familiar with FODMAPs, but for those that may not, be, or some of you may need a reminder. FODMAP is an acronym that stands for fermentable, which means these are carbohydrates that escape digestion, reach the colon, and create gas. The O stands for oligosaccharides, which are type of water-soluble fibers, fructans and galacto-oligosaccharides. Common sources would be wheat, onion, garlic, and beans. Disaccharides refers to lactose, which is in cow's milk, sheep's milk. Monosaccharides would refer to fructose when it's in excess of glucose in food, and polyols, which include sugar alcohols, which can be found naturally in foods such as apples and pears and cauliflower, and also as additives in mints, sugar-free mints, and gum. So FODMAPs have been shown in a variety of clinical trials to induce IBS symptoms. And these particular carbohydrates have two primary effects. One of them is that they pull water into the gut. That's osmotic effects. The smaller the FODMAP, the more osmotic it is. So fructose, being a monosaccharide, is the most osmotic, pulls water into the small intestine. The longer the FODMAP, which is the oligosaccharides, again, those are the fructans and the galacto-oligosaccharides, the greater the gas production is. So when our bacteria enjoy these delicious FODMAPs, they will create gas, and it could be methane, hydrogen, or carbon dioxide primarily. As Jane mentioned, when the bacteria in our intestine excuse me, consume the FODMAPs, they also produce what we call postbiotics. An example of that is these short chain fatty acids, butyrate being one of them, propionate and acetate. These can have some sort of downstream effects by changing the pH in the gut, increasing osmotic load. They can affect the motility, the sensation in the gut. And all of this in an individual with IBS can trigger GI symptoms such as pain, gas, bloating, and altered bowel movements. It's important to know that FODMAPs are a trigger in people with a sensitive intestine, such as IBS. They do not seem to bother or particularly problematic in individuals that do not have IBS. So there's no need to restrict FODMAPs if you do not have a sensitive gut such as IBS, and that's 85% of Americans do not probably have to avoid FODMAPs. But in individuals with IBS, a low FODMAP diet has been shown to be effective in up to 86% of individuals. So it can be a very effective therapy for people that are suffering with a very debilitating chronic health condition. But not everyone is appropriate for the low FODMAP diet. So as a clinician that is educated and worked with IBS patients for several decades, it seems like, I can tell you there is a screening process. So you want to make sure that an individual that comes to see you that has a diagnosis of IBS, that there isn't evidence of an eating disorder or maladaptive eating, such as ARFID, which is more of a feeding disorder. It stands for avoidant restrictive food intake disorder, or extreme food fears, because putting someone on an elimination style diet, such as the low FODMAP diet, could potentially trigger some of these conditions and contribute to even more restrictive eating, which is, of course, not anything that we would want to have a patient endure. We also want to make sure that their diet recall reveals that they're actually eating high FODMAP foods. We want to make sure that eating exacerbates symptoms. And an individual with IBS where eating does not exacerbate symptoms, it would be likely that they would benefit from a non-diet approach. You also want to ensure that the individual you're working with is interested in a nutritional approach to treatment, And then typically in an individual that comes to see me, if they have irritable bowel syndrome and it appears that they are suitable for the low FODMAP diet, I do want to have them go back to their primary care doctor or gastroenterologist and have a celiac serology testing done. And the reason why I do that before I implement a restrictive low FODMAP diet, it's because although the low FODMAP diet is not gluten-free, it is, you do reduce gluten because wheat, barley, and rye are sources of FODMAPs, and they are also the sources of gluten. So the low FODMAP diet does reduce gluten intake. And so we want to make sure that we're doing these blood tests for celiac disease to rule out this condition prior to implementing a diet that's going to modify gluten. In cases where there is an active eating disorder or ARFID or malnutrition or unwillingness to change diet or even a poor capacity to follow the diet, perhaps an individual that is food insecure or does not prepare their own food, maybe with children, or maybe when there's multiple dietary restrictions in place, one might consider what we call a FODMAP gentle approach versus a full engaged low FODMAP diet. And the low FODMAP gentle approach is really just taking a more flexible approach to the diet and really cherry picking out or removing the really particularly high FODMAP items in an individual's diet, rather than going through all the nuances and all the details that we would do with a full low FODMAP diet. So in an individual, for instance, that, is unwilling to change their diet, then they're not going to, adhere to the low FODMAP elimination diet. You'd want to think of some alternative therapies. Or if there's risk of malnutrition or inability to follow the diet fully, one might engage in more of a gentle, flexible approach. So to elaborate a little bit on this flexible approach to the low FODMAP diet, you could assess various food groups that have FODMAPs and restrict these very, more high sources of the FODMAPs. So for grains, instead of doing the full restriction of all the various high FODMAP grains, one might only restrict wheat and rye from an individual's diet. For vegetables, some of the key really high FODMAP vegetables would be restricted, such as onion and garlic, for instance, or leek, mushrooms, if that was something that was very prevalent in the individual's diet. There are fruits that tend to be higher in FODMAPs compared to others. Apples and pears and watermelon tend to have multiple FODMAPs and tend to add a little bit of an extra FODMAP load. So these are items that we would pull from the diet. And again, this would be appropriate for someone like an elderly woman or a child where we did not feel the full elimination diet would be appropriate. And I find that when I take this approach with a client, I really want to make sure that I'm looking at their 24-hour intake and food frequency. So I'm really identifying and personalizing this diet to the items that make sense for what they're consuming and provide alternative substitutes for them so that they can apply this modified approach. So in general, the FODMAP elimination diet, I hope that you all know by this time. I feel like this has been really emphasized in the research literature and elsewhere, that the diet is a 3-phase approach. The elimination phase lasts about 2 to 6 weeks. During this part of the diet, we remove all high FODMAP foods in an attempt to provide symptom resolution. And then we're switching over to the reintroduction phase. That lasts about 6 to 8 weeks, where we systematically add back various FODMAP subtypes. An example would be lactose or excess fructose, to identify what FODMAP subtypes may be problematic to that individual. Most individuals are not sensitive to every FODMAP. And at the very end, the personalization phase is really when we're adding back the foods that were successfully reintroduced to really expand the diet to the personal tolerance with more variety. Another important step in the low FODMAP elimination phase for success is that we're not only giving them a high FODMAP, low FODMAP checklist, we're really going through label reading, meal planning, suitable brand names, balanced nutrient-rich diet. We want to focus on fibers, make sure that they're eating enough calcium and a variety of nutrients for good health. We want to upfront in that first visit explain the 3 phases so that everyone's on board that the elimination phase is not the only phase of this diet. And then we want to provide substitutes for favorite foods. I think it's important that we don't encourage our patients to be perfect and strive for perfection, but just to do their best that they can. If an individual is put on a low FODMAP diet and they eat a slice of pizza, they don't need to start that elimination phase from the beginning. Just get back to their low FODMAP diet at the next meal. And sometimes when we make mistakes with the diet, we learn from them, and it's very telling about what's working and what might not be working in their diet. Just a brief overview of some of the high FODMAP foods. I'm not going to belabor this. It's really just a little graphic to kind of show you the various foods that can be high and various FODMAP subtypes. I have a grocery list. The Monash University has an app that's very helpful for implementing the low FODMAP phase, elimination phase. And I think it's also important as practitioners to understand that the low FODMAP diet, although it has sort of a reputation for being highly restrictive, it is a diet that includes all food groups and really allows many fruits and vegetables, which provide a great sources of fiber. And so this is just a picture that I took with low FODMAP fruits. And I think it can be very surprising to people when they've been told over and over again the diet's very restrictive. And I'm not suggesting that it's not restrictive, but I think that it's good to know that there are quite a bit of fruits and vegetables that are allowed on the diet. When you're implementing the diet, I think it's also important in what we're really seeing in the US, and which is really amazing to me, being, in the beginning in the trenches with the low FODMAP diet back in 2010, and now really seeing this just emergence of all these wonderful companies that are providing whether it's Epicured with low FODMAP and gluten-free meal delivery, or Monash certified low FODMAP foods. Individuals are being able to go to the grocery store and see a certification on a label. FODMAPs is starting to emerge in all the grocery stores here in the US. Char, Kellogg's, Green Valley. There's been a number of different food products that are being tested and showing up on the grocery shelves for people with IBS to identify. So I want to take this, that was sort of the background of the low FODMAP diet, and then how do we work with patients to make sure that they're actually getting adequate fiber sources. We know that fiber is important. Jane did a really great primer on bulking and feeding our microbiota, the role of some of these postbiotic effects of eating fiber, such as butyrate production. So we do want to really emphasize to our patients that, getting a variety of different types of fiber is important. Again, as Jane mentioned, it's not just about eating, 20 grams of oatmeal every day, getting 20 grams of fiber from oatmeal. We really want to provide a variety of different types of fibers. So in this little slide, you can see there's a number of foods that are low in FODMAPs that offer great sources of fiber. Canned lentils, for instance, 8 grams of fiber per half a cup. That's a great rich fiber source. Patients often will use lentils mixed with white rice and make a little pilaf. I've always encouraged my patients to include chia seeds sprinkled on their oatmeal. You can get 4 to 5 grams of fiber per tablespoon in chia seeds. So again, just trying to incorporate a lot of different types of fibers and incorporate this fiber chart or, fiber-rich foods in the meal planning that you do when you're working with patients, so they can see that there are plenty of fiber sources that are still allowed on the low FODMAP diet, and they should include a nice variety of fruits and grains, vegetables, and even plant-based proteins to enhance their fiber intake. On the right slide of this slide here, I provided a couple sample menus where I just tallied up all the fiber. You can see on the day one, I have 26 grams of fiber, which is a fabulous goal for most women. And then men, you want to get between 30 to 38 grams. Again, this isn't major rocket science, but you do need to pay attention to incorporate low FODMAP fiber sources at every meal. And know that individuals will tolerate different types of fibers. Even if they're low FODMAP fibers, some patients will not be able to do a whole lot of them at one meal. So spreading them out and just finding what works best for them. But it's an important discussion, particularly if they're constipated, to make sure that they're meeting their fiber needs. And I highlighted some of my favorite items that I personally consume from Epicured, just to show you some of their dishes. Really have a nice wide range of color, different types of fiber, and you can see, you know, this is nice dose of fiber in just a serving of these salad offerings. So I, of course, am all about getting fiber from plants and foods, because with that comes minerals and phytochemicals and a number of different health benefits, right? So, but there are some patients that just do better with supplements. And Monash has really taken the lead in certifying a lot of these various supplements, and I've listed some here that are low FODMAP certified, from Sun Fiber to Regular Girl, Women's Sense Fiber. Psyllium Husk is low FODMAP. And then, as you'll see on the right, is a FODMAP certified, Monash University certified product that is a seed blend that I absolutely love. It's a Vermont-based company, 5 grams of fiber, and it's a nice variety of different types of fibers in a 1/4 cup serving. So there's lots of ways to really easy tips to help your patients and yourself up your fiber if you're particularly sensitive to certain fibers. As Jane mentioned, fructans and galacto-oligosaccharides are common triggers. They're part of the FODMAP family and can be problematic for people with IBS. Now, that's not to say that they can't tolerate small amounts of garlic. Some patients are able to do that. So we don't want to discourage oligosaccharides if individuals can tolerate them. There's no reason to restrict a FODMAP if it doesn't trigger symptoms. But there will certainly be a number of your patients that you work with that the onion and garlic are a big trigger. So this is a great sort of chart that Jane Muir and Shanti Eswaran put together, Dr. Bill Che in the American Journal of Gastroenterology in 2013, really just talking specifically about different types of fibers, how long the chain length of the fiber is, and what are some food sources, the potential benefits or pitfalls, you know, as far as symptom exacerbation in IBS. And what I really just wanted to highlight here as a reminder that FODMAPs are short chain carbohydrates. They're not long chain. That doesn't mean that long chain fibers will not cause some gas and symptoms. They may do that. But when we're talking about fiber sources that are FODMAP sources, it's this first column up here, the oligosaccharides and the fructooligosaccharides and galacto-oligosaccharides that are found in beans and some nuts and wheat that really are rapidly fermentable and common triggers in IBS. I get a lot of questions, and I remember reaching out to Dr. Muir about this early in my game here about guar gum and pectin. These are not FODMAPs because they're a long chain fiber. And remember, FODMAPs are short chain. However, these are highly fermentable, and so they may lead to IBS symptoms when overconsumed. If you can get hold of this paper, and certainly I can feel free to reach out to me at Epicured. It's just Kate at Get Epicured. I can get you the link to this paper. It's a really, really well done paper. But keep in mind, that various fibers will have different effects on IBS symptoms, and probably these first two have the potential to be the most problematic. I absolutely encourage resistant starch as a good source of prebiotic fiber for these patients, but go slowly and just pay attention to how they do. Oats tend to work well in many patients. They do have a laxative effect. They don't hasten transit time, but their tolerance can be somewhat mixed in some patients. Skins of fruits and vegetables for someone with IBS-D or rapid transit can be a little problematic. For those with IBS-C or chronic idiopathic constipation, they can offer some health benefits in helping with laxation. It does hasten transit time, so moves things through. These non-fermentable fibers don't really grow beneficial bacteria. They're not really fermented, so they really don't have benefit from the gut microbiota standpoint. But this is a good paper should you be interested in learning a little bit more about the various fibers. So when you're working with patients with fibers, start slowly, especially with IBS patients, and make sure that you let the patient know that they should notice some change in gas and bloating as their gut environment adapts to this change in fiber. So we certainly don't want to induce pain and terrible bloating, but they should know that they'll be in a little bit of an adjustment period. As I mentioned earlier, I'm really about a food-first approach when possible. So try to incorporate food-based fibers first. Also realize that fiber is not necessarily, even though, for instance, resistant starch may have the benefit of increasing butyrate as a short-chain fatty acid in some people, but that doesn't happen for everyone because our bacteria are very individual, and so we have to have certain bacteria that are capable of breaking down resistant starch, and then those bacteria are also capable of making butyrate. So although resistant starch in the diet may increase butyrate, and that may be a benefit for some people might not have that exact same response because our bacteria are different. So we do have these differences in individual response to changing and adding fiber to food. One study from the American Gut Project showed that eating 30 plants per week versus 10 led to greater microbial diversity. And I think that this is, although this is one study, we do associate microbial diversity of a range of bacteria to be a sign of better gut health. So this might be a tangible goal for patients to try to work towards. So even just having them kind of think about that, like, are you eating 30 different plants every week? To really get them in tune to the fact that variety is important. Back to Jane Muir's point, different fibers do different things, and we want a variety of fibers so that we're having all of those health benefits. I also mentioned earlier that oligosaccharides as the O in FODMAPs may be a common IBS trigger, but that doesn't mean that patients can't tolerate any of them. So working towards getting a little bit of these prebiotic fibers in, if possible, if your patient tolerates them, that is a good goal. And then lastly, I just wanted to mention that there are some great resources. Monash University has the low FODMAP diet app, which is absolutely the best low FODMAP diet app out there. Their website, monashfodmap.com, has a number of recipes and a lot of really great topics. Easy to read for not only clinicians, but also people living with IBS. My website has a number of resources and recipes, as does Patsy Katsos, another leader in the FODMAP area here in the US. And Epicured, as Jamie mentioned earlier, has the Partners in Health resource page, which provides access to a number of complimentary webinars for credit through CDR, a FODMAP cheat sheet, and a number of clinician benefits. So check out the Partners in Health portal as well. And that is it from here. So happy to take questions. I know we just have about 5 minutes.
Yeah, we've got a ton of great questions. No surprise, we had a phenomenal turnout tonight. So thank you everyone for your questions. It's not too late to submit them here. We'll likely go over just a couple minutes if that's okay, Kate and Jane, given we've got about 8 questions here for everyone. Jane, let's start with you. Norm asks, first of all, thank you for your amazing work in the low FODMAP area. He's curious about the dark side of fiber, including their propensity to drive methanogens, methane, and constipation. He references the HO 2012 study and also the studies in the elderly and the archaea positive populations.
Is that for Jane?
I think so, but
yeah.
You ladies.
Okay, I think I'm not quite sure what the question. I mean, it's a comment. I think I agree that so the methanogens really, it seems to be people who have problems with constipation often have a high level of methanogens, and there's been some interesting studies in animal work, I think in dogs, showing that the methane actually does have effect on transit, slows down gut motility. So, but it's, yeah, the methanogens are a very, very interesting area, a complex area. And I guess switching people over from being sort of methane producers, I think is an area that needs a lot more research. And I do think that it's a combination of the sort of the population that people have, plus also the diet that they're eating, I'm sure are going to be part of the answer there. But I think it's, an area that needs more research.
Sure.
I'm hoping that answered the question. I'm not sure.
Yeah, feel free to ask a follow-up, Norm, if you had more detail that you wanted to ask for that. We can see your chat, Norm, so if you did have a follow-up, feel free to submit it. Suzanne would like to know, for her clients who are constipated, she recommends bran cereals, which looks like, to her, a safe non-FODMAP suggestion, but would you recommend that? And she thanks you both.
You mean bran as in wheat bran or oat bran?
Maybe you can speak to both.
Oh, okay. Or probably Kate will jump in too.
Sure.
Kate, I mean, because wheat bran is very high in fructan. So that would not be, if you have IBS, we're talking about IBS, someone who has IBS. Yeah. So that is not, I would not select wheat bran as your source of bran. You could probably certainly try an oat bran or a rice bran, however, which are low FODMAP and you maybe tolerate it better. And I don't know if Kate would like to.
Yeah, I mean, I think, just as a general, depending on the question, so I agree with Jane, I would opt for an oat bran or a rice bran in individuals with IBS. Wheat bran has actually been shown to not be very well tolerated in individuals with IBS, likely due to the fructan content. The bran tends to, in healthy people, it does irritate the colon and drive mucus secretion and can help with laxation. It's a kind of a mechanical irritant in a way. That's how wheat bran can help with one of the factors in how wheat bran can contribute to laxation, and obviously bulking, as Jane mentioned earlier, it's significant bulking ability. But yeah, we wouldn't use wheat bran in IBS typically.
Mm-hmm. Then are there differences in guidelines for those higher fiber recommendations for patients given a certain age? Like specifically, Sophia asked about patients that are over 50.
Yeah, the Institute of Medicine has, I don't have the facts right on my hand, at my ready, but typically for most adults up to about 50, it's like 25 to 38. It tends to decrease the fiber needs after 50, I believe. And then in individuals such as children, it tends to be, I believe, a little bit less. So it is, fiber needs vary by age and gender, and don't steadily increase. There is a drop off, I believe, after 50 or 51. But if you wanted to kind of pick a range, it's typically between like 21 to 38 grams for like the adult, female, male.
Mm-hmm. Now, Lori specifically works with teens that come to her very interested in low FODMAP, but they're starting with a very low fiber diet. So how would you approach fiber when putting them onto a low FODMAP diet? Would you try to adjust the fiber intake first?
I guess I personally would approach that individually. But if they were appropriate for a low FODMAP diet, an elimination diet, I would just try to include adding some fiber sources, even if it was just subtle, like add a handful of blueberries to your cereal in the morning, maybe a little sprinkle of chia on their peanut butter toast or something like that. And then we would kind of slowly amp up the fiber to their needs. I wouldn't want to have 50,000 dietary changes happening at once.
Mm-hmm.
So it's not like I'd bring a 17-year-old up to 38 grams of fiber and put them on a low FODMAP diet and do multiple changes. I'd always try to work off their framework of their diet and implement the low FODMAP diet with subtle changes, such as adding fibers over the course of the visits that I spent with the individual.
Mm-hmm.
And if I can just add there, I absolutely agree, Kate. And I guess the other thing is it depends what some of their symptoms may be, and you'll be adjusting to that. So if it's very constipated, have problems with constipation, your advice will be different to someone who has problems with diarrhea. And I think that you'll be working on ways to help minimize those types of symptoms with your recommendations as well. Is that right, Kate?
Absolutely. Yeah.
And we did have a specific question about IBS-C patients and the recommendations you'd give for insoluble fiber choices to help with the constipation.
Insoluble fiber?
Yeah, that was the question.
Yeah, I mean, often, I would just have them eating some of, first of all, I think it's one of the things that I've seen in clinic a lot, that people that are constipated or have irritable bowel syndrome, you do want to, with constipation predominance, you do want to make sure that they're on some kind of bowel regimen, or that they have some kind of rescue plan. So some people will come to my door, and they are so full of stool that adding fiber, this isn't my quote, but it's a fabulous quote, is like adding fiber to someone that's full of stool is like adding cars to a traffic jam. It doesn't necessarily help at that level. So I'm always working with the gastroenterologist to make sure that there's a good bowel regimen and that they're clearing the stool. And then we start titrating up the fiber. And in that case, they tend to do well. Patients do well with chia seeds. They do well with eating the skin of a potato and eating some of the skins of fruits and vegetables. If they're full of stool and you're just adding all this insoluble fiber, which is poorly broken down, and you're just adding more bulk, that usually backfires. So it does take a little work, making sure that they are using the bathroom every day, that they're feeling like they're getting a cleansing bowel movement, and then titrate up the fiber. If you feel like they're telling you that they haven't moved their bowels in 3 or 4 days, I'd want to work with the doctor to make sure we're establishing a good bowel regimen, and then titrate up the fiber, if that makes sense.
Mm-hmm. And Kate, you mentioned chia seeds. Kate would like to know if you'd ever recommend chia seeds in their unsoaked form, and can the unsoaked form of chia seeds cause obstructions in the gut?
I haven't heard of a case report of them causing an obstruction in the lower intestine. There was, I believe, a case report where someone ate chia seeds without adequate water and they did swell in the esophagus. I have patients use them often like in a chia seed or on top of their hot oats, and they kind of soften up a little bit, but I do encourage people to drink with them to clear and make sure that they're traveling down into their stomach. If someone had strictures or inflammatory bowel disease, that's where we have to be a little bit more careful with certain types of fibers, and I might not recommend chia seeds in that case. Although I'd love Jane to chime in, because I know she probably knows a little bit more about the type of fiber specific in chia seeds. I know it's kind of an unusual fiber, right?
Yeah, it's unusual because the fiber is on the outside of the seed. It's not on the inside. It's actually on the outside. And I know they grow them up in Northern Territory in Australia where it's very hot because they can't rain, hot and dry. You can't have rain near harvest because all the fibers on the outside, so it's a disaster. So the fibers on the outside, and I agree with Kate that you need to make sure you have plenty of water with it, and just maybe start with a small amount, a teaspoon or two to start with, and have plenty of fluid. But a lot of people make these quite nice drinks, and they add, some chia seeds to the drink of water, and they mix in some fruit, they'll have some strawberries or lime or something in there, and they make a nice drink that they can sip over the day, and then the chia seeds are well and truly hydrated. You can see they the fibers just swell on the outside, and that's quite a good way of having the chia seeds, a safe way as well. But start small and just see how you go if you've got concerns at all.
Mm-hmm. Great. Just a couple more quick questions. Kate, I've heard you answer this one before about probiotic use. Is it possible to overconsume and exacerbate IBS with probiotics?
I haven't seen like a study per se about a particular probiotic where it was truly exacerbated the symptoms. Are they effective in managing symptoms? There's definitely been some studies that show certain probiotics are effective in IBS and others less effective. Unfortunately, the research is kind of all over the place, and different types of bacteria that they're used, and the studies are very variable. So it's hard to compare a study head to head, which is what we want to do, is compare similar studies to see, does this make sense, or did the first study just happen by chance? I do think that in some patients, and that I've certainly experienced, and this is more like clinical observation, where they come in and they've had, buckets of kombucha, or they're overdoing it with fermented foods, or they've, doubled up on the probiotic dose that's on the box of the probiotic, and they're really miserable. So I think that they can be problematic. I haven't seen like a ton of data in the research setting, but from my clinical observations with patients, I've definitely seen them, have their symptoms exacerbated when they overdo probiotics and some of the fermented foods that are enriched with a lot of bacteria.
Mm-hmm. And then we have a question about celiac serology. What is considered an adequate gluten intake for that test?
2 slices of bread is generally acceptable. So obviously bread can vary, there could be the smallest little piece and a huge bulky roll or something. But the equivalent to 2 standard slices of bread over the course of about a month, every day.
Yeah. And then do you have a recommendation on how to start reinduction, which food or food groups to start with?
It really varies based on the patient's history. So if it seems pretty clear from my initial consultation that lactose is just really a problem for them, I wouldn't start with lactose. My goal of my first reintroduction is always to hopefully pass that one so that the individual gains a little confidence that, I'm not putting them through this miserable test to make them feel miserable. In my experience, I would say the majority, if I had to guess, the majority of my patients I've started with the polyols. So I usually will do mannitol and sorbitol challenges. Those seem to be often passed beautifully. If I had to do a guess on which FODMAPs pass most frequently, it's been the polyols. That's not to say that some people will fail a mannitol or a sorbitol challenge. That certainly does happen. But if I had to guess, that's probably the one I start with mostly and the one that most of my patients do pass. So I would go there. You could argue with me that we should start with oligosaccharides because they have prebiotic effects and that's a health benefit. So let's start there. And I would argue, well, most people, I'd say the majority of people don't do well with oligosaccharides, and then they don't feel real confident about going forward with the reintroductions. So that's sort of been the way I've handled it. I usually do the polyols first for most people.
Jane, any last comments or points on that topic?
Oh, no, I think I completely agree with Kate. That's very much, you want to give people encouragement to keep going with the reintroduction phase. So it's good to start somewhere. And often you sort of get a feeling for each patient which foods that they say that they're okay with too, and but certainly in the polyols, and I absolutely want to know that lactose is okay, because that's sort of such an important, the dairy is such an important group as well. But start somewhere where you think you're going to have success, and then take it forward from there. But the role of dietitian is vital in this. So and knowledge, the dietitian really needs to have very good knowledge about how to manage this condition, and it's quite involved, but it's very rewarding, isn't it, Kate?
Oh, most rewarding work I've ever done in my 30 years. Absolutely. When you can make someone that, lives every day in pain and feel better and ready to go travel and do the things that they, deserve to do, there's just nothing better. It's really been quite rewarding.
Well, that's beautiful. You guys are doing such amazing work for your patients, the community, for the clinicians who have attended. You've gotten a lot of thank yous in the questions as well. I did see there was a question from a patient. If there are any patients on the line, and for all of you to be aware, you clinicians also, both Kate's site and Monash University have directories of dietitians who come highly vetted and well-trained, who we should all be looking to provide evidence-based care. So please check out their directories. I hope to see you all on our next webinar, which is coming up very soon. We'll send you all this recording, an invitation for our next webinar, and access to the CPE certificate tomorrow. And I hope you're all well and wonderful. Thank you again from the bottom of our hearts, Kate and Jane, for your time this evening and for sharing your expertise. This was a wonderful reprieve from a difficult time, and very engaging. So thank you so much.
It's a pleasure. Thanks, everyone.
Thank you, everyone. Have a good evening.
Have a good evening. Bye-bye.
Bye.
Bye.